let's talk about pharmacotherapy for fluid and electrolyte balance. Again, I'm assuming that you guys have diuretics somewhere else, possibly in your kidney or cardiac units, but it's also something that we use to control fluids. In this case, we've talked a little bit about isotonic, hypotonic, hypertonic solutions. I'll go into that in a little bit more detail, but I'm going to just tell you what you need to know, not just for this class, but this is something that's just going to keep coming up and coming up and coming up. In your practicum, you need to know the difference between these things. You need to be able to determine, what kind of side effects you're looking for and so on. Let's talk about potassium chloride supplements first. So when do we give these? Well, we give them when a patient has low potassium. So patients hypokalemic, we're going to actually give potassium supplements. These are oral, they're giant white pills that most patients have a hard time swallowing and often have to cut them in half. So that's a little bit of a pain. So that's kind of a mechanism of action is really, it's a straight replacement. We're replacing the potassium that's been lost. Desired effect, we want to, again, replace that. And we've talked about potassium is incredibly, incredibly important for muscle function, but especially has negative connotations for the heart muscle. If we have hypo or hyperkalemia, we're going to end up with ECG changes, arrhythmias that are life or death. They're life-threatening arrhythmias. So when a patient comes into the ER, for example, with severe hyperkalemia, we take that very, very seriously, treat it as quickly as possible. And we talked about on the other slide, I think one of the ways we do that is through using insulin, right? And then let's talk about some of the side effects. Yes, you might have some nausea, vomiting, diarrhea. None of these are super, I don't want to say they're not important, common, because they are. You need to have an idea of, but they're not something that we see happen all the time. So on like a cardiology unit, almost every patient is on some kind of diuretic. Diuretics cause, and we won't talk about why, but they cause a decrease or a loss of potassium. And so a lot of these patients will have hypokalemia. So they're on potassium supplements as well. And so, we give these every day to patients, and these things are not usually enough of an issue to stop giving the medication. And of course, hyperkalemia, anytime we're giving a medication, we want to make sure we're not giving too much. These patients will have blood work done every day, usually every morning when you come in. Their blood work will have hopefully been done. Sodium, potassium, glucose, anything else depending on their diagnosis will be done. So we want to watch that potassium level very, very carefully, as we don't want to cause hyperkalemia by giving a potassium pill. So you will have an order for potassium daily, and you come in and you go to give your meds and you see that the patient's potassium is already 5.2. You're going to hold that potassium. You're not going to give it. You're going to hold it, let the physician know, and they can decide what to do from there. So let's look at these little questions that they're asking. Why do we have to assess kidney function? We talked about what does the kidney do in relation to potassium earlier. We talked about the kidney is happiest, right, when it is doing its job to reabsorb sodium and water and excrete potassium. And so if we are going to give potassium, we want to make sure that the kidneys are working well enough that they're going to be able to excrete the extra potassium. Otherwise, we're just going to end up with, again, hyperkalemia. There's an interesting question just at the bottom of this. So why would concurrent use of potassium-sparing diuretics and ACE inhibitors lead to hyperkalemia? So I haven't looked at this yet, but let's think it through. Let's just, this is kind of how I how I answer, even sometimes answer test questions. So this one's easy. We know that I just told you that diuretics tend to cause hypokalemia, so they tend to flush out potassium. We do have one kind of diuretic, spironolactone, that is specifically spares that potassium, so it doesn't cause hypokalemia. And so what it does is it works to ensure that this excretion of potassium isn't happening at the same level as it normally is. So normally when we take a diuretic, all of this, we've increased this output, this urine output, right? And so all of this potassium is kind of flushed out with the urine. That's why it causes hypokalemia. However, if we put a little bit of a stop to this, we use a potassium sparing diuretic, it's going to stop most of that, or a good chunk of that potassium, from leaving the body. So what does it do? Well, it ends up getting reabsorbed back into the bloodstream. And so that's how we can end up with hyperkalemia. So if we use it concurrently with an ACE inhibitor, so let's follow that through. Let's talk about, we talked earlier about what an ACE inhibitor does. And this will have a lot to do with our renin-angiotensin-aldosterone system. So we said that an ACE inhibitor will stop angiotensin 1 from turning into angiotensin 2. And so it stops this excretion or release of aldosterone. So what does aldosterone do? Let's draw my little kidney again. Aldosterone, I think of it as, remember I said the kidney's happy when it's reabsorbing sodium and water, and excreting potassium. So I think of it as aldosterone. Aldosterone kicks this into high gear. It causes even more sodium and fluid, water, to be reabsorbed into the body, and then even more potassium to be excreted. So when this renin-angiotensin system is working properly, it's causing the body to hold on to fluids, to water and sodium, and it encourages the body to excrete potassium. So if we use something, for example, an ACE inhibitor, that blocks that aldosterone from even being created, we're going to slow this whole thing down, or stop it from happening. And so it's what we're going to see is less of this potassium being excreted, because it doesn't have the aldosterone there that's kicking that function into high gear. And so we're actually going to see the kidney holding on to this potassium and then reabsorbing it back into the bloodstream. And so we're going to end up again with the hyperkalemia. And that's how both of these things will cause hyperkalemia.